At the outset, I would like to thank Dr. Mettu sir for inviting me here and Team Star and my colleagues Srinivas, Sunil, Raghu, all of you. Thank you so much for inviting me here. The topic is a little complex, liver transplantation for alcohol-associated hepatitis. This leading indication probably in India, in our hospital especially, is now alcohol-related ACLF and alcohol-related alcoholic hepatitis, and probably decompensated cirrhosis due to NASH. If you see the epidemiology, the use of alcohol is significantly high. The recent data which is published in BMJ says that although there is reduction in the death due to alcohol and there is increasing deaths due to drug-related abuse, we still see that alcohol contributes to 5% of death and disability associated life years. It has impact over 200 diseases and types of injuries. In India, this accounts for 22% of the deaths due to liver disease and 20% of deaths due to liver cancer. Alcohol is the main culprit. Why we discuss about alcohol consumption in Telangana? Because we stand number 2 in consumption. We are just 10% away from defeating Arunachal. Arunachal is the highest consumption of alcohol, followed by Telangana, then Sikkim. While in females, it's in Arunachal again, then Sikkim, Assam and Telangana. 6.7% in Telangana, and in rural areas we see around 1.6%. We have been doing some rural-based research now, but what we see is 65% of rural area individuals consume alcohol. So alcohol is pretty high, a huge burden. And when we discuss about alcohol-associated hepatitis, this is a severe form of alcohol-related liver disease. The problem with alcohol-associated hepatitis is at least 4 out of 5 will present as ACLF. This was the ARC-based analysis which was published in Hepatology International, and they found out that 30% are only eligible for steroids. So 4 out of 5 of alcoholic hepatitis will present as ACLF, that is they have extrahepatic organ failures, they have infections not suitable for any kind of medical management. We also have no drugs for this alcoholic hepatitis. That's the reason we need transplant for these patients. There is one drug which has shown some benefit for these patients, DUR928, but it has shown beneficial only in American settings, not in UK or other settings. There is no animal model for alcohol-associated hepatitis. That is the reason we struggle with developing any drug for this disease. As of now, the medical management is hovered only around steroids. That's the reason we are stuck with only liver transplant as the best therapy for these patients. Currently in US, alcoholic hepatitis is the leading indication for transplant. There is 5 to 8-fold increase in transplant for alcoholic hepatitis. They are doing multiple research to reduce the burden of alcohol-associated hepatitis, and at least this early transplant for this patient costs around $300,000 per patient in US. The burden is pretty high in US as well as in India. But the problem is the differentiation between alcohol-associated hepatitis and alcohol-related ACLF. This is a table which we had recently published in liver transplantation. This may not be true in all extent, but what we usually see is if the patient has large liver, mild ascites, no or grade 1 varices, elevated bilirubin and INR, and EST elevation and more than 200, in less than 400, then we think it is probably just alcoholic hepatitis, not ACLF. If an individual has other gross ascites, grade 3 or more ascites, which large varices, and has bilirubin, modest elevation of bilirubin, and also has enzymes which is not pretty high, but the platelets are low, indicating chronicity in those patients, and the probably patient has ACLF. These kind of patients require upfront transplant. They may not respond to steroids. The response to steroids in them ranges between 38 to 50% in those patients. Well, if the patient has pure alcoholic hepatitis, the response to steroids ranges between 75 to 80% in those patients, and probably transplant, without transplant, they may recover to some certain extent. Coming to transplant, the pivotal study which was published in NEJM, they said that it has excellent survival, but they chose they had very strict criteria for transplanting those patients. It has a very small group of patients, 25 to 30 patients who underwent early transplant. They included only those who were not responding to medical therapy, where severe alcoholic hepatitis was the first liver decompensating event, and there were no coexisting psychiatric disorders, and the patient had a favorable psychosocial profile. These were the individuals who were chosen for early transplant. I will not be talking about only transplant. It is mainly around early liver transplant for these patients. But what actually is early, this definition is very not clear. When we did some review of this definition, early LT for AH is defined as transplant without a prerequisite period of alcohol abstinence. That we have made it as 6 months. So it's actually not 6 months is the actual not cutoff which has been defined in any literature. This was based on 1994 study which was published in Hepatology, where Jack Lake was the senior author, where he said that 6 months, if you do a transplant within 6 months, these individuals tend to relapse more. That is the reason we came to a definition of early transplant as less than 6 months, but it is actually just defined as without a prerequisite period of alcohol abstinence. What are the predictors of post-transplant relapse? We see the post-transplant, we see the relapse is in around 20 to 25% of patients, and 8 to 10% will have severe relapse. These are usually young patients who have more than 10 drinks per day, those who do not have family support, those with a history of psychiatric illness, those who have concomitant substance abuse. These are the individuals who have high risk for relapse post-transplant. So it is dependent on abstinence. To transplant or not is dependent on abstinence, liver disease severity, psychosocial aspects, and probably yes, we need the donor for these patients to undergo transplant. This is our experience which was published in Annals of Hepatology. We had only 25 patients who underwent liver transplant early. The median abstinence they were around 23 days, that is 3 months. MELD at the time of transplant was 28 and DF was 104. Almost 70% survived more than 1 year. So survival for these patients was low because we also used steroids for these patients, and they had most of these patients developed infections post-transplant. 3 died due to fungal sepsis, 2 had bacterial sepsis, and 1 developed COVID. The relapse rate was 20% and severe relapse was around 8 to 10%. When we compared with other transplant centers, it was similar. This is from Dr. Narendra Chaudhary's group, 39 steroid ineligible patients who underwent transplant. Age was 43. This is the critical age where we see around 40 to 45 years alcohol-related ACLFs who come to us planning for transplant. They have an abstinence period of 4 to 6 months in that study. And there was the survival is better compared to non-AH ARLD and alcohol hepatitis related ARLD. Relapse rate again around 12%. Higher infection. This is a struggle in India. We have 70% of MDR bugs in India, which was published in Gastro by Piano study. We have a high burden of MDR bugs in India. So probably that is the reason we have high infection rate. 71% developed infections in alcoholic hepatitis group compared to 50% in non-AH group. Again, in Korea, they have reported around 9 LDLT for these patients. 14 days within listing, they underwent transplant. And third one is the one study which I quoted already. So early transplant has excellent survival, but the problem is availability. In Asia, only 18 to 20% we can offer early transplant. This is a survey-based study which was published in Lancet GastroHep. In Canada, it is 100%. US, 97%. So every alcoholic hepatitis is immediately listed for transplant. That is the reason they are doing research to identify patients who will not require transplant early. While in Asia we have only 18%, that is 1 out of 5 we may undergo transplant early for alcohol-associated hepatitis. What happens when the patient relapses post-transplant? How does it impact the survival? This was a study which was published in CGH, Lee BP, which he actually has worked multiple articles on early transplant for alcoholic hepatitis. There they saw 4 patterns of alcohol relapse post-transplant. Most of them were abstinent. Those who were abstinent had significant survival benefit even at 5 years. In pattern 2, these patients who had late non-heavy alcohol use, their survival was also good. That is, patient after 1 year, if he starts drinking and he is not consuming in heavy amounts, only occasional slips, their survival will not be impaired. But those who have early non-heavy and early heavy, their survival is significantly impaired. Although at 1 year the survival may remain same, post 1 year their survival significantly decreases at 2, 3 and 4 years. And in those who have early heavy alcohol use, their survival is hardly 50% at 5 years. In this study, they actually had questionnaire-based assessment of alcohol use. They also monitored through biomarkers, that is PEth test was done in certain patients, in 75% of the patients. And they said that early relapse is a significant predictor of poor survival for alcohol-associated hepatitis. And how do we diagnose alcohol use disorder in clinic? That is our common question for patients pre and post-transplant. These are the traditional biomarkers which are already available in, which have been using regularly. What we see is MCV. When the patient comes to us, if the MCV is elevated, it is quite sensitive to identify alcohol use. We also see the AST, ALT elevations. We see the GGT levels. But the one which has come to recently to market is the PEth testing, which is a marker of the red blood cell. This gets converted into phospholipid, gets converted into phosphatidylcholine in the presence of alcohol. This is the PEth test which have been suggested for alcohol to identify alcohol use post-transplant on the second right-hand side. If the PEth is less than 10, then the patient may not have alcohol consumption. If it is between 10 to 20, there is some alcohol exposure. He may require repeat PEth testing. If it is between 20 to 35, there is high or risk of alcohol exposure. If it is more than 35, he definitely is consuming alcohol. PEth has to be measured by LCMS method, which is a very costly method, very sensitive method. We have started performing ELISA for this, and we find it to be useful in clinical practice. There are certain scores to predict alcohol use post-transplant. The one which has been actually published and recommended by guidelines is the SALT score, which is sustained alcohol use post-liver transplant. A score more than 5 indicates high risk of relapse. These are the comparisons between the two. When I use this score in our clinical practice, most of our patients have a score of 8. So I don't know whether it is relevant to Indian settings. We need more research on this aspect. Last but not least, please identify these patients who have risk of alcohol abuse and treat them with these medications which are available. We have naltrexone, which is freely available, 50 mg per day. We also use acamprosate 333 mg thrice daily. Baclofen, although not approved, but can be used for these patients. And in the use of we need to send them for psychological counseling, but our patients are quite reluctant to undergo psychiatric counseling. And although we have been trying to send them to psychiatric counseling, this is a very poorly conducted systematic review published in CGH, where they said that the combination of CBT and MET, motivational enhancement training and cognitive behavioral therapy, along with medications, will help them remain abstinent from alcohol. To summarize, what we suggest is a proposal which was published recently. If you have a patient who his MELD score is 25 to 35, he has disease severity which is alcoholic hepatitis without AKI or only HRS AKI, good performance status, has no risk of relapse post-transplant and good control of infections, he may be an ideal candidate to undergo transplant if there is good family support. If a patient has any of these which is fitting in blue criteria, he may not be an ideal candidate, you have to wait and reassess. If the patient has very poor family support and has not been engaging with alcohol, engaged with abstinence and mental health care, he may not be an ideal candidate. He should be delisted and should be avoided from providing liver. To summarize, alcohol-associated hepatitis and alcohol-related ACLF is now a major indication for transplant, and early transplant provides excellent survival, at least 70 to 80% in these patients. Indian data shows the feasibility, but there is need for strict infection control and psychosocial support, which we probably lack to some extent. Self-reporting, relapse prediction tools which are there, and biomarkers are essential to identify alcohol use. MAT, that is medication-assisted treatment, and motivational interviewing, that is just spend 5 minutes with them to remain abstinent from alcohol, they will probably quit alcohol. CBT and MET have to be done by a psychologist. If the patient agrees, then probably you can go ahead with CBT and MET. I'd like to take this opportunity to invite you all for our liver conclave, which is being held on 26th and 27th of September. Look forward to seeing you all again next month. Thank you so much.
Thank you, sir. Thank you for lucid presentation. And I have one question for you, sir. Suppose particularly in such cases, if transplant is delayed some or other reason, is there any role of FMT, fecal microbial transplantation?
FMT, we have not seen any great results. We initially tried FMT in our center. We usually prefer to do plasma exchange as a bridging therapy for time being. If the patient is not infected, we do plasma exchange and then probably take them for transplant once they are stabilized.
Questions from audience?
Thank you, Anand. This was a great talk, actually, as usual. What I wanted to know was, we see more and more of these patients who come to us. They've been in another hospital, had steroids, got multiple infections that have come. In the Indian setting, with the kind of MDR bugs that we're having, are there any clear subset of patients where steroids are actually indicated if your patient presents with alcoholic hepatitis?
So what we usually see is that if the procalcitonin is low, even if he harbors those VREs, which has been routinely done as from all the orifices to identify, they usually respond well. If the patient has frank gross ascites, who has very small liver and very high bilirubins with renal failure, we usually avoid giving steroids. If they have good liver reserve, only elevated bilirubin with mild ascites, no varices, good platelet levels, probably they will respond well to steroids.
Thank you. And I think I was impressed by one slide of yours, the paper from CGH, where you shown that if you remain abstinent after transplantation, your survival is, 5-year survival is nearly 100%.
100% survival.
That just shows that, these are patients who, if they actually stick to the word, then they do very well with transplantation.
And I think that's definitely true over here, but our patients, they tend to relapse whatever said and done. At least they have occasional slips. And PEth might be useful in identifying those patients.
Thank you.
Thank you.